I'm a colorectal surgeon at North Bristol NHS Trust, which means I operate on bowels and bottoms. So some of the stuff that I'm going to talk about, I'm not an expert in, and the expertise lies with everyone in the room. This is our AHSN. For those of you who do not know, the AHSNs are 15 regions in the country, and we're appropriately shaded brown for me over there. And we range from Gloucester to Swindon to WEAHSN. And we're in a unique position to improve patient safety because the AHSN is us. We are a member, a network of organisations which crosses acute care, community, mental health, the ambulance service, and our community providers, as well as our local universities. I think a lot of you in the room will be familiar with the South West Safer Care Collaborative. So that was a patient safety collaborative launched by Sir Ian Carruthers, which consisted mainly of 18 acute trusts in the South West, and that was the whole of the South West, working on patient safety, very much along the lines of the Safer Patient Initiative with ward work streams, perioperative work streams, leadership, various other work streams. And there is a real benefit for those of you who haven't worked in a collaborative before of sharing learning, stealing other people's ideas, working together to reduce the variation in care. And that was amazing. And we really showed some changes and improvements in mortality across the South West. But we were mainly 18 acute trusts. Later on, there was a mental health collaborative, which I'll talk about later. But really, we were mainly acute trusts at that time. And so what the AHSN can do, which is us, and I try to think about, well, what's different about the AHSN? And I think there are two main things. One is that we have the opportunity to make a change across the whole health system. And it's amazing today, there are people here from primary care, secondary care, mental health trusts. So we can do something really different that a collaborative of acute trusts alone cannot do. And the second thing is we know that people can only do things right 95% of the time. And I think that with innovation, we can get to 100%. And the AHSN is in a unique position, I think, to try and link those things together. So ultimately, I'm hoping that if we have ideas that need innovation to help us solve, the AHSN is in a position to help link those two things together and get industry and our ideas together. So this is our work plan. It looks very complicated, and don't worry, I don't expect you to read that. So there are 5 main projects that we are planning to do. And I say we because they've come from the member organisations in this room. So this is our big one, which is to implement an early warning score across the system. An early warning score is an objective measure of how sick a patient is. So that's an observation chart. It's colour-coded into red, amber, green. You add up a score depending on where the observations fall, and the higher the score, the sicker the patient is. And we know that this is better than clinical judgment. So we're very excited with the opportunity to implement this across the system. What our vision is that when a GP refers a patient in, that we will have a set of observations, which ultimately will be in the form of a news score. The ambulance service can then send an ambulance at the correct priority to the sickest patients. The ambulance will also use a news score. In Scotland, we've used that as they've used it as an opportunity to identify sepsis early, because if the patient triggers a news score of a particular level, they immediately go on to do a sepsis screening test, and then they can't apply the sepsis 6, but they apply the sepsis 5. If a patient has a high EWS score, that patient goes straight in to resus in their ED departments. So what we are hoping is that we will start to use this as a mechanism for identifying how sick a patient is, as a mechanism for getting the right patient to the right place at the right time, as a mechanism for recognition of sepsis, but also mainly that we're speaking the same language, because currently an EWS score in North Bristol of 4 is not the same as an EWS score of 4 in Bath. And this is a way that will help us to communicate how sick a patient is. The other thing that's important is what happens with a new score. When an EWS score is introduced in hospitals, there are standard actions that have to happen. If a patient scores greater than 4, certain things have to happen. It's not that we just have the score, there's an escalation. And that is supported by structured communication. Everyone will be familiar with situation background assessment response, which is a structured way of asking for help about a patient. And this leads us very nicely on to the next project. For those of you that are unfamiliar with human factors are those non-technical skills that help us work as a team and keep patients safe. So they're focusing on how a junior member of staff can raise a concern, how you communicate if you're worried a patient is ill, how you can challenge poor behaviour. And this also gives us the opportunity to reinforce the SBAR communication. Another main project is incident reporting in primary care. In hospitals, we all know these statistics, 10% experience an adverse event during a hospital admission, and 50% of these adverse events are avoidable. And over the last 10 years in secondary care, patient safety has become a big thing, recognising harm, recognising that things are avoidable, and putting a lot of work in to try and prevent it happening. In primary care, we don't really know quite so much. And we know that in secondary care, we normalise our harm. We talk about recognised complications. We talk about surgery, saying, well, it's risky, these things happen. Healthcare-associated infections, we used to say, well, C. diff, well, that's what you get if you're sick. A central line infection, well, that's what you get if you're on ITU and you're not very well and you're a bit immunosuppressed. But we now know that those things can be changed. And the idea of starting incident reporting in primary care is to start that questioning of what we do, and also recognising that things may be happening that we don't even know. So we have all this now in a hospital. We have dashboards and we look at incident reports and measure things. And this is just an aim to start measuring things in primary care. There is a national incident reporting system already, which we've had demonstrated to primary care and clinical commissioning groups. So the tool is already out there. And also it's about a healthy reporting culture. What we want are lots of incidents with no harm or low harm, and hopefully not so many with severe harm and death. So that's our big primary care project. And that's going to take some time to do. We're not going to do this in a year, but it's a start to start the conversation about patient safety. And we also know that currently, we're very reactive in healthcare. But what we want to be is we want to be like the nuclear industry, where we look forward and think, could this happen here? What could happen? And that's what we want to be in acute care and primary care. So our third project is around emergency laparotomy. Now, we know that there are lots of reports showing that emergency surgery is not done as well as it should be in this country. And there has been a project called the ELP-QUIC project, which some of you from Bath will be familiar with. So it was 4 hospitals led by Kent, Surrey and Sussex, and they applied some evidence-based measures to patients undergoing emergency laparotomy. So all patients to have an early warning score completed. There we go, that links to our project already, which is brilliant. Broad spectrum antibiotics to be given. Well, that links with the work we want to do on sepsis and linking it to the early warning score. Timing to laparotomy, making sure patients get to theatre quickly. Goal-directed therapy, which for the anaesthetists in the room you'll all be familiar with. And finally, patients having emergency laparotomy to go to intensive care. Now, what the ELP-QUIC study showed was that some hospitals managed to implement this better than others. And this is the NHS, and not every hospital managed to do all those things. And when we spread this, we won't all be able to do this. We won't all be able to send every patient to intensive care. But despite that, most hospitals, well, one showed a very slight reduction, but in general, there was a reduction in 30-day mortality of 25%. And if you take that to the sickest patients, it was 30%. So the aim of this project is to spread that work throughout our 6 acute trusts. Medicines management, there is already a very well-established network of medicines management throughout the AHSN. And the other thing that links very nicely is that we think that there's a big role for pharmacists in incident reporting in primary care. But the AHSN is also going to carry on providing support to some other work that's going on. So the Mental Health Collaborative is already well established. It's this AHSN plus 4 others. We're also providing support to work on sepsis. That's being led by Lindsay Scott from NHS England. So that's the work stream, and I think we've got a real opportunity to improve patient care across the system. And these are the people that are going to help you to do that. Thank you.